excitable. If you're excitable, what does that mean? You're ready to go, right? You're excited. You're ready for something to happen, right? Okay? Our wives, girlfriends, whatever, say, hey, come on. Right? We're excited. We're ready to go, right? Conductivity is the ability to pass on the electrical impulse. Okay? The ability to be able to carry the impulse to neighboring cells is conductivity. The ability to be able to conduct the electrical impulse. Automaticity is the ability to be able to say, the hell with you, I am going to generate my own impulse. Okay? So they're excited, they're ready for that impulse, they're ready for action. When that action occurs, they can conduct it to their neighbor who's also self-excited and ready to go. All right? And then they have that automaticity to be able to go, okay, I'm going to fire off myself. And the last feature that they have is they have the ability to be able to contract, obviously. Okay, those cells need to be able to contract in order to move blood out of the heart. Okay? So all of those things. So we move into what are called pacemaker cells now. So these are the heart cells. So the electrical conduction of the cell, these are specialized conduction tissues that take the electrical impulse to the muscular tissue. Okay? Top down. All right? And it has to come down in an organized way in order to allow for the top of the heart to be able to squeeze, and then to allow for that little stretch of the ventricles, and then to allow for the ventricles to be able to fire. So in order for that to be timed, the electrical impulse has to come from somewhere and move through the heart in a coordinated way. So that each one of those cells who are excited and ready for the impulse will get the order to go ahead and fire. Okay? All right. So pacemakers. These are areas of the conduction system where the impulses are likely to start. These are your dominant pacemakers. Okay? And it's an area where electrical activity arises and sets the rate for cardiac contraction. So they're fixed. They have a fixed range of where they're going to contract. Okay? So the first one we're going to talk about is we're going to talk about the SA node, the sinoatrial node. It's the dominant pacemaker. So what I want you to do is I want you to think of, you're driving down the road and you see this flashing amber light in the distance. All right? What does that tell you?
Something's coming up.
Something's coming up, right? And it's very bright, too. You can see it a good distance away, right? So I want you to think of the SA node as being that bright light that's going to shine. Okay? Very intense. Okay? So the sinoatrial node is located in the right atrium, and it receives its blood from the right coronary artery. So each one of the pacemaker sites, they have to have oxygen too. They have to get blood flow. And just so we can have pump performance issues, we can have electrical issues as well that will affect the pump performance. Okay? All right, it's the fastest pacemaker, and so then we have the impulse that's delivered. So let's walk through how this is delivered. So the SA node is the primary pacemaker. It's firing hopefully in all of us right now. The SA node fires off, and then it moves down what are called the internodal tracts. Okay? Very fast highways that basically take the impulse and they move it down the conduit. Jumps over what are called gap junctions and jumps over to the right or to the left atrium, and the impulse is delivered to the tissues. Okay? Then the impulse, as it's moving down the internodal pathways and it's working its way over to the right or to the left atrium, hits the AV node and the bundle. These are the gatekeeper. So the impulse comes down, and the bundle, the AV, says stop, hold. I'm going to hold the impulse. I don't want you to go yet. Why do you think it wants to hold the impulse?
It's too high, too much. It needs to slow it down.
Okay, why does it need to slow? What's going on in the heart that it would need to slow down for? Before you answer this question, let me tell you what happens. At the right time, then it comes down and it hits the bundles, and it's like the Autobahn. Okay? It just comes down, hits the left and the right bundles, hits the Purkinje's, and causes the ventricles to fire. So why the hesitation?
It's waiting for the ventricles to fill.
Ventricles to what? Not fill, they've already filled, but the ventricles to do what?
To pump and to snap to the way.
Atrial kick, go with that.
Closing the valve.
Okay? So what it's doing at the gatekeeper is that it's saying, hold on, it allows for that atrial kick and that ventricle to get tense, and then sends the impulse down the superhighway, the Autobahn, that rapidly accelerates it, gets to the Purkinje's, and the Purkinje's go, okay, causes the ventricle to snap.
So the AV node is waiting for the atrium to fill?
Not the atrius to fill. What it's doing is it's allowing for the atria or the ventricles to get that last little stuff and ready to go. That's what the hesitation. Because if I didn't have this, I would have the it would just come down just boom, 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 and so I would never get atrial filling. I would never get that atrial kick. That's why you have to have that hesitation to allow for that final little stuffing in order for the ventricles to kick in. Okay? All right. So top portion of the conduction in the atria comes from the SA node in the internodal pathways. The impulse is held here. Okay? Atrias contract, they stuff the ventricles, then it sends the signal on down, hits the left and the right bundle to the Purkinje's, and then they start the impulse. Okay? So these cells that are sitting there excited and ready to go, they're ready to fire off, and just as the Purkinje's deliver the impulse, that's what starts this chemical shift inside the sodium and the potassium pumps, all of that stuff to start, ultimately getting that ventricle to contract. Okay? So these cells are sitting down here at the gatekeeper. Think of the batter box. Guys up here ready to go, right? I'm up here ready for the ball to come down. I'm ready to go. I'm excited. I'm ready. I'm ready. I'm ready. Here comes the impulse. Boom. And that impulse to go is the ball with the bat, but it's also the Purkinje sending it. Okay? Now once the Purkinje let the signal go, the impulse, then it's a cell-to-cell depolarization. Okay, it's a cell-to-cell depolarization. Okay, so it's a wave that works. So it begins to contract this way and begins to contract this way. If it all contracts at the same time, I'm not going to get good emptying of the ventricle because I need for the ventricle to empty in a coordinated way in order to squeeze the blood out. Okay, so that's why it's cell to cell. I get the bottoms beginning to empty and squeeze it out at the top. Does that make sense? Versus all at once. Okay? All right. What's the problem with somebody having a rapid heart rate? We'll use the term supraventricular tachycardia, or SVT. Their heart rate's 150, 220, 280 beats a minute.
You're not allowing that ventricle to be able to get that filling.
Perfect, Reggie. That's absolutely right. 100% on the money. It cuts down on the ventricular filling. The faster the heart rate, the less filling time. Okay? So you got to have that timing to allow for that. And so those are the patients, you know, will a 50-year-old patient, will they handle a heart rate of 180 beats per minute okay? You see them all the time. We give them adenosine, vagal maneuvers, and all that stuff. But what about an 80-year-old? Will she tolerate the same heart rate? Probably not, because the heart, you know, may have some issues and stuff. So it's all relevant to the pump itself. All right. So any questions at all about the conduction as it's coming down? Normal pathway. Okay. So the three dominant pacemaker sites are SA node's the first one. AV node the second one. And the Purkinje's are the third one. The dominant is the SA node. Now if something happens and the SA node is unable to conduct the impulse, the heart says, okay, AV node, step up. And the AV node will step up. Okay? If the AV node can't step up for some reason, then the Purkinje's will step up and be the dominant pacemaker. Okay? What can cause them? Disease can cause them. Certainly MI can cause them because they're all fed by blood supply. Okay? So there's lots of different reasons. We'll get into those more specifically, but those are them. So each one of them have their intrinsic rate that they beat. So in other words, normal rates for the SA node are between 60 and 100. Okay? 60 and 100 is my normal range. What does the term bradycardia mean? Low or slower heart rate, right? And what does the term tachycardia mean? Fast heart rate, okay? If I'm looking at a sinus rhythm, and that heart rate is below 60, what do I call that?
Junctional rate.
No?
Sinus bradycardia.
Sinus bradycardia. Okay, bradycardia is slow, and it's at the sinus, not junction. That would be at the next one down. Okay? So if my rate is less than 60, it would be a sinus bradycardia. What if my heart rate was 102? It would be a sinus tachycardia. Okay? Now let's jump down to the next one. Is AV junction, or the junction. Its intrinsic rates are 40 to 60. Okay? What if I had a patient who was in a junctional rhythm, but their rate was 32? What would that be called?
Sinus junction.
Would not be sinus. You can't use sinus because it's not in the sinus. Sinus is SA node, so it's now junction. Junctional bradycardia. Okay, because I know that the normal rate for the junction is 40 to 60, so a bradycardia, a slow junctional rhythm, would be a rate less than 40. All right? If I have a junctional rhythm and their rate is 102, what would that be called? Junctional tachycardia. Okay? Now here's where this gets gray. So that if their heart rate is between 60 and 100 in the junction, you know what we call that? It would be an accelerated junctional. Okay? Here's where it's just a little bit different. So the normal intrinsic rate is 40 to 60. If it's lower than 40, it's going to be a junctional bradycardia. If it's over 100, it's a junctional tach. And if it's between 60 and 100, it's going to be an accelerated junctional. Just think accelerated, a junctional rhythm that's just accelerated above its intrinsic rate. Over 100, just think tachycardia every time. Over 100, tachycardia. Over 100, tachycardia. Okay? All right. Then the next one is the Purkinje's, which is that lower level. And of course, if it's low, it's going to be a slower heart rate. Okay? So the lower from the SA node, the slower the heart rate's going to be. So the Purkinje's beat between 20 and 40 beats per minute. Okay? All right. So we typically call those ventricular rhythms. All right? So if my heart rate is, and it's a ventricular rhythm, okay, and my heart rate is between 40 and 100, what would it be called?
Accelerated ventricular.
Very good. An accelerated ventricular rhythm. If it's over 100, what would it be? VTAC, ventricular tachycardia. See how this works? Okay? Now here's the deal. If it's less than 20, it wouldn't be a ventricular bradycardia. It would actually be what's called an idioventricular rhythm. Just a very slow, idio means we don't know where it's coming from. It's just a slow, it's usually a peri-arrest rhythm, which means they're getting ready to die. Okay? And so that's kind of, so you understand the difference between those, where all those are? And so when these next couple of weeks, we're going to be going in and seeing sinus braids, sinus tach, junctional bradycardias, accelerated junctional tachs. You're going to learn all those, okay? But that's where those things come from.
You have to use a 12 lead to determine which,
Nope, not necessarily. A 12 lead will certainly help, but no, you can look at them from the EKG strip to be able to tell that. All right, so we understand now, and I'm going to do this, I'm going to introduce this, and then we're going to go to lunch and come back, and we'll revisit it, and then we'll watch a short video on this. So we understand the anatomy, we understand the blood flow, we understand the coronary arteries, we understand the conduction system and how it moves down. All right. Now we need to talk about what happens in the cells. When that impulse comes down, something has to happen in those cells in order to have them be excited and to contract and to do all those things. And what we're talking about is we're talking about the influence of electrolytes or chemicals. And there's there's more, but the three dominant electrolytes we're talking about is potassium, sodium, and calcium. Those three. See, your heart cells are bathed in electrolyte solutions. Okay? And on the outside of these cells is a lot of sodium. Okay? So one of your questions on your exam is which one is the chief extracellular, extra meaning out, extracellular electrolyte, and it's always sodium. Sodium's always on the outside, sodium out. And one of the ways that I like to think about it is, let's think about a boat on the ocean. Where's the salt water?
Outside the boat.
Outside the boat. Okay? Sodium's outside the boat. So if I get a hole in the boat, I want to move the sodium out of the boat. Okay? So sodium's always outside the cell. Okay, and if it's inside, it's pumped out of the cell. And we'll talk about the sodium channels and all that stuff, the sodium pumps. All right. On the inside, the intracellular is potassium. Potassium's on the inside of the cell. Potassium in, sodium on the outside. Okay? And it's simply the exchange of these electrolytes that create a change in electrical current within the cell that causes that muscle to contract. So it's that change in that electricity, if you will, within the cell that causes it to contract. Okay? Now, one of the other things to think about is that here's a cell. I have cells that are obviously up against each other, right? And inside of these cells, we have little gap junctions or little holes that allow for cells to communicate back and forth. So remember what I said, the properties of the cardiac cells are what? One of them is the ability to conduct. Okay? So all of these are, they're excited, ready to go. They can automaticity, they can create their own impulse, and they can contract. Okay? And as I said before, as the ventricles contract, it's cell-to-cell depolarization, cell-to-cell contraction. So when we come back from lunch, we're going to find out how that energy is changed inside the cell to cause this cell to contract and transmit all this to the neighboring cells so that it works its way across. Okay? And that's done through the sodium-potassium pumps. Okay? So I just wanted to introduce these concepts to you because it's going to lead us up into talking about refractory periods and of course this video. All right. What questions do you have? Anything at all? Is everybody leaving for lunch? Leaving the property for lunch? All right, here's what I'm gonna do, because I like I'm 10 minutes early, all right? And I was gonna give you till 1 o'clock, and I think an hour and 20 minutes is a long time, isn't it? Do you wanna start earlier, or do you wanna just be back at 1?
Try to get it done a little earlier, if that means we can come back much earlier, but that's just me.
Me as well.
Okay.
If that's how it works out.
Yeah. So I tell you what, why don't we be back at, how about this, how about 12:45? You have an hour and 5 minutes for lunch, we'll come back and we'll catch it on the opposite end, okay?